Welcome to the Mod4PH Research Highlights. This is a public health podcast produced by the National Collaborating Center for Infectious Diseases. My name is Wendy Xie, and I'm a project manager at NCCID. In this podcast series, we showcase math modeling concepts and research for application in public health. This is the fourth episode in a 5-part mini-series highlighting the research and methods from the Artificial Intelligence and Mathematical Modeling Lab, or AIMM Lab, directed by Dr. Jude Kong at the University of Toronto. Joining us today are Dr. Zahra Movahedi and Dr. Gelan Zewdie. Dr. Zahra Movahedi is a postdoctoral fellow at the AIMM Lab. Her research is centered around the integration of AI to enhance decision-making processes in public health. Dr. Gelan Zewdie is a postdoctoral fellow at the AIMM Lab, whose research is focused on harnessing AI for disease surveillance, diagnosis, and equitable healthcare delivery, particularly in digital health solutions designed for community use. In this episode, we invite Zahra to describe her work in the use of AI and unconventional data sources to develop an early warning system for respiratory infectious diseases, while Gelan will highlight the impact of co-developed community-specific digital tools and how these tools can be leveraged by communities to advocate for improved health programming. Hello to everyone listening in, and a huge welcome to Zahra and Gelan. Thank you both for joining us today. Would you please say hello to our listeners and give a quick self-introduction, please?
Hello, thank you very much for your invitation. It's a pleasure to be here, and I'm very excited to share our work. My name is Zahra, and I'm a researcher at AIMM Lab. My background is computer science, and my field of interest is machine learning, data analytics, and natural language processing.
Thank you. My name is Gelan Zewdie. I'm a provost postdoctoral fellow at the University of Toronto, Dalalana School of Public Health. I'm currently at AIMM Lab, working at the intersection of AI and public health. I am a biomedical engineer by training, and my research focuses on community-based disease surveillance using artificial intelligence. It's really a pleasure being here. I look forward to this engaging conversation that we have here. Thank you.
Thank you both again for being a part of this mini-series. It's great for me to learn more about all the work that your lab is doing. So first, let's share some more details on Zahra's research. Zahra, would you please describe the primary research project that you are involved in and some context for why this work is so important?
Absolutely, yes. My research involves surveillance of infectious diseases, particularly respiratory infections, and I am mainly focused on building early warning systems which can help and support public health in controlling and containing the spread of diseases. And so the emergence of COVID-19 pandemic highlighted the need and necessity of early warning systems. So at the core of our system, there is a forecasting model that leverages deep learning to predict potential reemergence of respiratory outbreaks. And what sets our work apart is the use of unconventional data, or what we call social data. So instead of relying solely on clinical or laboratory data for building the forecasting model, we incorporate real-time signals from platforms such as Google Trends, Reddit, and Facebook. And by integrating these social signals, we aim to create a more responsive and timely tool for public health decision-making.
Thank you so much, Zahra. You mentioned, social signals, real-time social signals, and that is the type of unconventional data that you're using in the development of this early warning system for infectious diseases. And you already covered a little bit about what you mean by conventional data. Could you tell us a bit more about what this unconventional data can tell us, or what can this type of data do that conventional data cannot in the context of this early warning system?
Yes, of course, a great question. Like when I say unconventional data, I'm referring to sources that fall outside the traditional healthcare and epidemiological systems. Conventional data like hospital admissions, ambulance dispatches, telephone triage logs, and in case of avian influenza, environmental samplings, they are very valuable, but they also face a lot of limitations. Collecting these data, it could be very expensive and time consuming. It needs a lot of manpower, and the result is reported with a great delay, like several weeks of delay. In contrast, unconventional data, such as Google Trends, social media posts, online news articles, and even weather and air quality data, which can be collected from Google Earth Engine, they could be very beneficial because we can have access to them with less effort and less amount of time. Like with several lines of code, we can have access to this data. So it could be very convenient because it could be done without human intervention. And also the result could be accessed in real time or near real time because these data are regularly updated. For example, maybe with at maximum with several days of delay, we can have access to this data. So it could be very beneficial to the forecasting model. And also a great advantage is that they can be collected without human intervention. So basically we can use them to automate the machine learning pipeline or basically automate the data collection stage. And also what makes this data especially useful is that they are significantly correlated. They are most often significantly correlated with the number of cases because they reflect population behavior. For example, if people in a community start experiencing a symptom, they most likely what they will do is that they will first of all go and search about it in Google search engine. And then they will also discuss it on social media platforms such as Reddit and Facebook. And also there will be a spike in Google News coverage. So they can be great tools for building the forecasting model, and incorporating these unconventional data sources can make the early warning system faster, more efficient, and more accurate.
Thank you so much, Zahra. It sounds like the use of unconventional data definitely addresses a lot of the problems that we have experienced using conventional data. So I actually have a bit more of a technical question for you. So you mentioned various different types of unconventional data sources. You mentioned social media, there was air quality in there as well. And I'm wondering, in the development of these forecast models, how do you weigh these different data sources? Are you trying combinations to see what works well in prediction? Do you find that different conventional sources are better at predicting future events compared to others?
Yes, definitely. When building the early warning system or using deep learning models, so basically we use a multivariate model, and we can use different indicators for building this model. So we fit these different signals into the model, and most often feeding these different signals, it does increase the final accuracy of the model. And all of these, they play their own role, they have their own contribution. And because we're working on respiratory infections, weather data and also air quality data, they are very important actually. They play a significant role. And yeah, eventually when we add these data sources to the model, we can see the accuracy little by little increases. And yes, all of them are important. They all play their own role in building the final model. Yes.
Thank you so much for that, Zahra. So we talked a little bit about data privacy in the previous episode with your teammate Abbas. Are there similar data privacy or data bias concerns when using unconventional data sources in these prediction and surveillance forecast models? And if so, how are you addressing these in your work?
Yes, data privacy is definitely an important concern when using unconventional data, and it's essential to address it carefully, especially in public health applications. So on the privacy side, most of the unconventional data that we use, like Google Trends or aggregated social media data, they are publicly available and anonymized. We don't access individual level information or anything personally identifiable. For example, with Google Trends, we only see search interest aggregated by topic and region, not who searched for them and for what reason. Similarly, when using social media data, we focus on general patterns, keywords, or sentiment trends across large populations, not tracking individual users. So the focus is on aggregated signals, which helps minimize privacy risks. And in terms of bias, yes, these data sources can reflect certain populations more than others. For example, social media use varies by age, socioeconomic status, and geographic locations, which can introduce biases into the models if not handled properly. So, to address this issue, we validate our models against more traditional surveillance data to ensure they're not just accurate in general, but also equitable across different groups and communities. So, let's say while there are valid concerns, there are also responsible ways to use this data that prioritize both ethical use and public health impact.
That's fantastic. Thank you so much, Zahra. So, for listeners, Zahra was also a guest speaker on the Surveillance Advances seminar series. So, if you would like to hear more details about her work, please follow the link below this episode, or you can find it under the webcasts tab on the NCCID website. So, next, let's discuss the research that Gelan is leading. Gelan, would you please give us a summary of the work that you are doing as a part of the AIMM lab?
Thank you, Wendy. My research basically focuses on developing community-driven AI-enabled disease surveillance and outbreak prediction tools. Particularly, we focus on low resource and underserved communities. And I work on multiple health threats, including measles, mpox, and polio, and other infectious diseases, where I integrate multimodal data such as text, image, video, and geospatial information to enhance early detection and response. Not only that, my work also focuses on AI governance, ethics, and decolonization to ensure that the technologies and the solutions that we developed are equitable, context-aware, and locally impactful. That is what I'm working on.
To get a little bit more specific about your project, when you're talking about community specific tools, what is the main region of focus for your work currently?
Currently, we are focusing on global south, for particularly in Ethiopia, where we have low resource settings such as pastoralist communities, border area, and those marginalized communities. That is the target community that we build these AI-powered tools.
And in previous conversations that we've had, I know that collaboration and the co-development process are crucial aspects of your work. Would you please share some more details related to the engagement that was done to allow for such community-specific tools, and maybe what has been the response or impact so far in terms of infectious disease monitoring and management in these communities?
All right, let me unpack your question in two parts. Let's talk first about the first part about co-creation and co-development and collaboration. Collaboration and co-development, I call it co-creation. These are the core of my approach, as the goal is to build those tools that are not only technically sound, but also contextually relevant and trusted by the communities they serve, because we are developing those tools for those communities to use. So we have different levels of engagement. We typically begin with the needs assessment and participatory workshops, where we involve local public health authorities, community health workers, and also the whole affected population to understand what are the existing surveillance practices, and then what do those surveillance practices have as challenges, and what are the priorities that those surveillance systems focus on. And then we then co-design those system features with those stakeholders by ensuring that the local value, by ensuring that the cultural appropriateness of the society, the community that we focus on, even language is accessible, and then the alignment with the local flow, workflows. And then during development, we maintain technically iterative feedback loops. We do some pilot testing, and then focus groups, and then regular stakeholder consultations, which will allow users to directly shape the tool's interface and data inputs and then reporting mechanisms. And when we talk about partnership, it extends across various areas where academic institutions, ministries of health, we are working with Ministry of Health, Ethiopian Ministry of Health. At the same time, we are working with Ethiopian Public Health Institute. We are working with non-governmental organizations and grassroots organizations such as Core Group Ethiopia, which enable a blend of technical expertise and at the same time lived experience. This will allow us to increase the adoption rate and the sustainability of the tools that we develop, but also at the same time, it fosters local capability, and also communities will adapt and use the tool over time. And the other question that you asked me is, what is like the response on the impact of the tools that we develop? The response has been really encouraging. We did pilot tests in different places, and the AI-enabled surveillance tools have improved timeliness and accuracy of outbreak detection, which is, we call it sensitivity, with certain diseases such as polio and now measles and also mpox. These diseases being flagged days ahead or weeks ahead when compared to conventional reporting system. At the same time, community health workers and the local public health teams, they are reporting with greater confidence, which will help them to make, really calculated decision. And these tools that we develop are providing them with actionable inputs and location-specific alerts. And also, we are providing them with a good visual dashboards. At the same time, the systems that we have developed strengthen the reporting completeness, which is very crucial because the surveillance data that are collected from this population, they are not complete. They lack a completeness. And also, in some cases, this early warning capability has supported faster deployment of even vaccination campaigns and targeted public health interventions, reducing the risk of wider transmission. So in total, beyond immediate disease control, the engagement process has fostered trust, digital literacy, and local ownership, laying the ground for sustainable and community-driven monitoring. Back to you.
Thank you so much, Gelan. One of my follow-up questions was actually, how do you ensure that as many community members participate in the use of these tools? But you've already covered that it's through very high levels of engagement and co-creation, as you said. That's extremely exciting to hear. And maybe we should have gone into this earlier. I want to learn a bit more about the actual tool that you're talking about. So this is an app that we're talking about, right? So if I were a community member and I access this app and I have questions, or I'm feeling some symptoms and I want to report, what does the app actually look like for a user, for the community level, and then also maybe the public health level?
Yeah, so we have different tools. For example, if I give you one of the widely used tool by the community and by government, our mobile app for polio surveillance, which is called Polio Antenna. So we have four types of users, one of which is the community. So if you are, for example, a community volunteer, you will be registered by us because community volunteers are nominated by the community to report cases within the community. And then what you will do is you log into the mobile system. And then when you see some sort of acute flaccid paralysis within the children under 5, you will start recording. You ask the parents if they are willing to report this case. Once they give you the consent to report those data, you will collect text information, which is basically about the demographic information and the symptoms. At the same time, acute flaccid paralysis can be information can be obtained with visual cues. So you take image, and then how you move also impacts whether that is acute flaccid paralysis, to determine whether that is acute flaccid paralysis or not. And then you take a video. All those information will be uploaded to our system, built-in AI system. The AI system analyzes and says, okay, this case might be acute flaccid paralysis or polio, and I am saying this with 66% confidence. So do this, do that, do that. And at the same time, it reports to all health authorities and concerned NGOs and local authorities that data that has been collected. That way, we are improving how cases are found, at the same time helping the community to make informed decision based on the findings of our AI tool. This tool works in local three languages. One is English and two local languages. At the same time, for example, let's say you don't have internet on your phone. It will collect that data, it puts, and when you move to a location where there is internet, it will send that information. So that way, we are trying to involve like the technology component and also the local context. So yeah, that's the tool, one example of a tool that we developed.
Very interesting, Gelan. Thank you for sharing that. I'm glad I asked because I had no idea that so much information gets input into this tool that you described. I didn't know that there was a video component involved, but that is very interesting. Thank you so much for
Yes.
sharing. Yeah.
This is being scaled to other diseases, visual diseases. For example, if you take measles, you can use image and video of the skin on top of the symptoms to detect that disease early, which is really a huge issue back in the global south as well as in Canada. At the same time, mpox is another issue. So now we are building for those systems, and we are about to pilot those. It is in under-house pilot testing. So we
Yeah.
are scaling this system to other diseases. That's what I want to say.
Speaking of scaling, I guess you mentioned that, these pilot projects are happening in Ethiopia right now. How do you think these digital health solutions and tools that you've described can be applied to communities and public health in Canada? Do you expect certain challenges, maybe same or different challenges? And how do you think you would address these obstacles?
Thank you for that question, Wendy. As you know, this digital health solution that we are developing, particularly AI-powered community-driven disease surveillance tools, they have very strong potential for application in Canada, not in Canada, globally. They could support real-time monitoring and rapid response for outbreaks in underserved or geographically remote communities, for example, in Canada, such as rural, northern, and indigenous population. And by integrating local knowledge with the public health data sets, these tools could improve early detection, for example, for seasonal illnesses, emerging infectious diseases. Measles is an issue here in Canada also, and even non-communicable health threats that require community level monitoring. For example, let me tell you, we are working with Greater Toronto area long-term care homes, and also in collaboration with Stat Canada and Toronto Public Health to bring this community tool to long-term tools where we use this tool to detect early infectious disease outbreaks within those nursing homes. So like, it's not something for Ethiopia. It can easily be adopted to Canadian context for many reasons. However, the case of Ethiopia and Canada is a little bit different because Canada presents its own unique challenge, right? For example, data governance and privacy regulations are stringent here, which require solutions to meet high standards of security and ethical use of personal health information, right? And also, digital divide persists in remote areas where internet connectivity, device availability, and digital literacy may be limited. And additionally, very importantly, is trust. Trust in data system must be actively cultivated, especially in communities with historic and ongoing concerns about external data use in indigenous and other part of. So to address these obstacles, I think the solution should be, as I said earlier, co-creation, co-design with communities, respecting indigenous data sovereignty principle. Like in Canada, we have principles such as OCAP, ownership, control, access, and possession. And also, when we do the technical design, we must prioritize simple tools which will enable us to have offline functionality and also interoperable platforms and low bandwidth performance. Most importantly, we need to create relationship. We need to create partnership with the local health authorities, community organization, and trusted leaders. This can ensure that the adoption is both culturally appropriate and operationally sustainable. Like if I give you one example, last week I was at a conference in Calgary where I was presenting this work, and one elder approached me. She liked our work. Like she's indigenous and she liked our work, and she said, like, we can use this for our community. So by going there, by approaching them, by showing them what you are doing, how you create that relationship, and then that way you can realize those challenges that come from the community side can be solved. So it is about co-creating. It is about creating that genuine relationship with the community that will solve these problems. Without that, we cannot go anywhere. Like there is a saying that my supervisor, Professor Kong, says always, I have many applications on my phone, but if I don't use it, it is just an application. Like, we don't need to create application which just sit on our phone, but which are used by the community. And that needs co-creation and that partnership. Back to you, Wendy.
Very, very excited to see the growth of this project. And I can tell already the absolute potential that it has for communities and public health in Canada. And it's very exciting to hear that when you were presenting this work, you're already getting so many positive responses. That's extremely encouraging and exciting to hear. So thank you both to Zahra and Gelan for joining me today to talk about your work at the AIMM Lab. Do you have any final comments or maybe any resources you would like to share with listeners who are interested in learning more about this work?
Thank you very much. It's been a pleasure. I just like to say that as we face growing risks from infectious diseases, integrating AI with real-time unconventional data offers a powerful way to detect and respond to outbreaks earlier. And I just believe that it's an exciting step towards smarter, faster, and more accessible public health systems.
Thank you. I want to close by saying that as important community-based disease surveillance is, we have to make sure that co-creation is the central theme of whatever we do. It must be rooted in decolonization, community partnership, and equity, ensuring that technology empowers rather than, repeat the same thing that happened in the past. By combining local knowledge systems with ethical use of AI, we can build efficient, faster, more fairer, and more trusted health surveillance that serves everyone globally, maybe those people who are historically left out. Finally, I want to thank all organizations who support AI Lab, including International Development Research Center of Canada, and also the FCDO, the UK's agency, and also other organizations in Ethiopia that help our research really have impact on the local community and also help us implementing our idea. Back to you.
Thank you both so much for joining us for this mini-series. I, of course, look forward to speaking with you both again very soon, maybe some updates on your work, and I'm sure we're all looking forward to the future of both of your projects. Thank you so much.
Thank you.
Thank you very much.
This concludes our conversation with Dr. Zahra Movahedi and Dr. Gelan Zewdie. Please stay tuned for the final episode in this 5-part miniseries highlighting the important modeling work from the AI-MM lab. In the last episode of this miniseries, we invite Dr. Zewdie back for final reflections on the research being conducted at the AI-MM lab and where he would like to take this work in the future. If you have any other questions about this episode or would like another math modeling concept or researcher featured on this podcast series, please write to us at nccid@umanitoba.ca. Production of this podcast has been made possible through a financial contribution from the Public Health Agency of Canada, but the views expressed here do not necessarily represent those of the agency. Learn more at nccid.ca.